Welcome friends. I am Dr. Baldev Prajapati, Professor Emeritus and Director, Medical Education and Research, Baldev Medical College and Hospital Kadi, located in North Gujarat. These are my 4 books published in the field of pediatrics, particularly on procedures, signs and symptoms, clinical pediatrics, and very specific on OSCE, spotters, and viva. Today I am going to talk with you on the jaundice, very common topic in our daily practice. Friends, jaundice is defined as a condition characterized by yellowish discoloration of sclera and skin due to increase in the serum bilirubin level. Clinical detection of the jaundice indicate that serum bilirubin is more than 2 milligram per deciliter in older children and more than 5 milligram per deciliter in neonates. One should always look for jaundice in the natural light, very important point. It is very difficult to appreciate jaundice in artificial light when particularly jaundice is mild, and that too especially the fluorescent light. Mild jaundice is easily missed in the artificial light. Even sometimes parents consider the severe pallor as the jaundice due to the yellow halo, which is mistaken as the jaundice, which as a clinician we should keep in mind. Dark color urine due to concentrated urine in a case of dehydration or decreased oral intake of fluids, high fever, etc. should not be mistaken for jaundice. Yellow urine can also be due to certain drugs like vitamin B complex, rifampicin, etc. And therefore, these causes first should be ruled out. Please keep in mind that in a case of jaundice, first urine appears yellow. Then the sclera. Skin becomes yellowish last due to very significant increase in serum bilirubin levels, and that happens especially in obstructive jaundice. Let me draw attention to some of the points where it is mistaken for the jaundice. That is carotenemia. It is seen in children with the consumption of lots of the carrots and mangoes due to carotene in them. Also seen in hypothyroidism and diabetes mellitus due to impaired conversion of carotene into vitamin A. The yellow pigmentation in carotenemia is mainly seen in the palms, soles and the face. Carotene is fat soluble and hence it is not concentrated in fat poor tissues like the sclera. So, sclera is not yellow in a case of carotenemia, but skin is yellow in a case of carotenemia. Another condition is lycopenia. Lycopenia is a carotene-like pigment seen in tomato, beets, berries. And the child who has consumed these particularly things in excess, they can also develop lycopenia, and therefore skin is looking yellowish. Even drugs like mepacrin, which is antimalarial, nowadays not used, or our quinacrine hydrochloride, that is antiparasitic and which was used in the treatment of giardiasis in the past, they can also cause the yellowish discoloration of the skin in almost 30% of the patients treated with them. And they can also cause the yellow discoloration of eyes. So, drugs should also be kept in mind. Now, how will recognize the jaundice? Look for the jaundice at sclera, palate and under surface of the tongue. bilirubin in the skin is obscured by the melanin, and therefore it is easier to appreciate jaundice in areas of skin not commonly exposed to the sun and is relatively free of melanin, like the skin of abdomen, palm and soles, which remain the cover. In the dark color children, jaundice can be best seen in the sclera and under surface of the tongue. And there is no difficulty in recognizing jaundice in Indian neonates, as increased skin pigmentation appears usually after 2 weeks of life. Let us see very important point, examination of a neonate for jaundice. In the neonate, it is difficult to examine sclera due to physiological photophobia, and one should not try to open the eyes forcibly. For assessment of jaundice in neonates, press the skin against a bony surface, commonly on sternum, for 5 seconds to blanch the skin and observe the skin color. Due to physiological polycythemia in the newborn, blanching of the skin is required to appreciate yellow color of the skin. It can also be examined over forehead and tip of the nose. In newborn, if jaundice is clinically detectable, if it is seen, it means bilirubin is more than 5 mg per deciliter. In neonates, the intensity of jaundice increases. There is cephalocaudal progression. This is due to relative thickness of the skin at various parts being thinner over the face and thickest in the palms and soles. In neonates conjugated, very direct hyperbilirubinemia is defined as direct serum bilirubin more than 1 mg per deciliter irrespective of total serum bilirubin level, and it requires different approach. Common causes of neonatal jaundice, please keep in mind, if it is unconjugated variety, physiological jaundice is the most common. Hemolytic disease of the newborn may be due to Rh incompatibility, ABO incompatibility, or even minor group incompatibility. There may be the breastfeeding jaundice, that means child is not getting proper breastfeeding amount, and that is lactation problem, and therefore goes for the dehydration and concentration of the bilirubin and leads to the jaundice. And breastfeed jaundice is something different, where some metabolite substance like 5 alpha 20 beta pregnanediol does not allow the bilirubin to conjugate, and therefore its level increases. That is the breast milk, and therefore breastfeeding and breast milk jaundice, these two entities should be very clearly defined. There may be even increased extravascular bilirubin load due to kiphilohematoma, swallowed maternal blood, etc. Upper GI obstruction like hypertrophic pyloric stenosis during atresia can also lead to the increased bilirubin, indirect bilirubin level. If it is unconjugated, again may be the G6PD deficiency, hereditary spherocytosis, hypothyroidism, Crigler-Najjar syndrome, Gilbert syndrome, hepatocellular jaundice due to the various conditions, or even the cholestatic jaundice. Please remember this very important card which I want to share the information. That is infant stool color card. Above these 3 are the abnormal colors and below 3 are the normal colors. What is the importance of this card? I am going to share with you. On this card, as I said, first 3 colors 1, 2, 3 are abnormal. They are clay color, pale yellowish or light yellowish, whereas below 3 to 4 are labeled as normal and they are yellow, brown and greenish. Abnormal color of the stool helps the parent to suspect the biliary atresia at the earliest 4 weeks, so that even management can be started earlier and the results are good. Therefore, share this card with the parents and to compare the color of the stool of that child, so that they can understand the abnormality at the earliest. Normal stool has a brownish color due to the presence of stercobilin, all of us know. In biliary atresia, stercobilin synthesis is markedly decreased as bilirubin cannot reach the intestine, and therefore the stool color is white or the clay color, and that becomes a very important clue for suspecting the biliary atresia. Please friends, remember the sensitivity of this test is almost 90% and specificity 99%. That means most reliable, very simple, I will say, modality which helps for detection of the biliary atresia at the earliest. Please remember some common causes of chronic cholestatic jaundice in the newborns. If it is obstructive variety, surgical condition may be biliary atresia, choledochal cyst, esophageal bile syndrome, gallstone or neonatal sclerosing cholangitis. Neonatal hepatitis due to the various infections like herpes simplex, cytomegalo, HIV, parvovirus, occasionally sepsis, UTI or even the congenital syphilis. Metabolic causes and some syndromes like galactosemia, tyrosinemia, progressive familial intrahepatic cholestasis, Down syndrome, Alagille syndrome, and even the endocrinal disorders like hypothyroidism, hyperpituitarism, maybe some drugs or even parental nutrition responsible for the cholestasis. Always I am talking to my students that in a case of jaundice in older children, look at the color of the urine, sclera and the stool. If the color of the urine is yellow, sclera is yellow and stool of normal brown color, it is hepatocellular problem, most common viral hepatitis or even the Wilson disease. But once the color of the urine is normal and there is a light yellow or tinge, many times it is a greenish tinge on the sclera and stool is normal, but severe pallor is noted, very important features of hemolytic condition. And when dark yellow urine, dark yellow stool, dark yellow urine, dark yellow sclera and clay color or white color stool, and if the child is itching, on examination if you get the scratch mark, I think nothing else is required to label that it is the obstructive jaundice. Very common causes of jaundice in children, most common is viral, all of us know, hepatotropic viruses like hepatitis A, hepatitis B, C, D or even the E. Non-hepatotropic viruses can also cause jaundice like Epstein-Barr virus, cytomegalo, herpes simplex, mumps. Other viruses even like dengue, Ebola, bacterial infections, the complication can lead to the jaundice like enteric fever, septicemia, leptospirosis. Protozoal conditions like malaria, Kala-Azar, toxoplasmosis can also cause the jaundice. Metabolic conditions should always be kept in mind like Wilson, tyrosinemia, galactosemia, hereditary fructose intolerance or even fatty acid oxidative disorders. Drugs many times responsible for the jaundice which we should not miss, like anti-tubercular drug like INH, rifampicin, pyrazinamide, non-steroidal anti-inflammatory drugs, even paracetamol occasionally, anti-epileptic drugs like sodium valproate is known to cause this hepatic problem, and some of even the toxins are also common which we should not miss. Thank you very much. Friends, before I end, I request you to subscribe over this channel, and if you subscribe every time you will get some new informations very useful in the exams and in the daily practice. Thank you. Thanks a lot.